Hello, I'm Jay Geary coming to you from the University of Pennsylvania. Thank you so much for this opportunity to comment on the excellent work by Dr. Agarwal from the University of Michigan. To put his case in perspective, let's talk a little bit about CTEPH, or chronic thromboembolic pulmonary hypertension. This is a disorder that will occur in 3 to 5% of patients who present to the hospital with symptomatic pulmonary embolism, and you'll usually diagnose them with it 6 months to 2 years after their incident PE diagnosis. Now, CTEPH is associated with significant impairment in exertional capacity, and it's also associated with increased mortality in those who suffer from it. Importantly, it's the only form of pulmonary hypertension which has the potential for a true cure through either surgical or interventional therapies. Now, Dr. Agarwal presented an outstanding case today that outlined the complex decision-making, techniques, and tremendous labor that goes into treating a CTEPH patient with balloon pulmonary angioplasty, or BPA. This technique, BPA, was pioneered in Japan, but is now available at several centers in both Europe and the US, with the promulgation in the US actually being led by the group at UC San Diego, which includes our former SCAI president, Atisha Mahmood. As this technique develops, it's important to keep our eyes on what is necessary to get good results and also identify the areas of uncertainty that could lead to systematic improvement in outcomes going forward. First, and most importantly, it's critical that BPA is viewed as just one tool in a comprehensive program that treats CTEPH patients. Much as we have seen multidisciplinary heart teams develop for the management and decision-making around complex coronary and valvular heart disease, a multi-specialty approach to the management of CTEPH is critical. At minimum, a CTEPH team should have the expertise of a medical pulmonary hypertensive specialist, a diagnostic chest radiologist, a pulmonary thromboendarterectomy surgeon, and an endovascular interventional specialist. Extensive workups are performed in these patients that include multimodality, non-invasive imaging, invasive angiography, and objective characterization of a patient's functional status, comorbidities, and their responses to previous medical therapies. Similarly, multidisciplinary decisions are then made to select patients for conservative medical management versus surgery versus interventional approaches, based both on the anatomic and comorbid considerations of that individual patient. Now, Dr. Agarwal nicely covered some of the considerations that are currently at play for selecting a BPA strategy in an individual patient. And while he is a true expert at the technical performance of the case, some of the issues he alluded to that could come up bear re-emphasis. Most important among these is the incidence of pulmonary artery rupture or hemorrhage during these cases. Single center reports from multiple countries demonstrate a roughly 3% pulmonary hemorrhage rate on a per case basis. But we have to keep in mind that the average BPA patient has 3.5 to 4 total sessions of BPA. When you take this into account, the rates of hemorrhage may be up to 10% per patient. So the resources, equipment, and knowledge for managing this relatively common complication is mandatory for successful performance of BPA cases. Now, thankfully, these rates are dropping with continued technical modification of the performance of BPA in expert centers. These include strategies such as more conservative balloon sizing, pressure catheter assessment of lesions, as Dr. Agarwal beautifully demonstrated, and intravascular imaging utilization in some cases. But in order for this field to reach its true potential, carefully conducted prospective trials of these various technical decisions will be needed that aim to find the right balance between procedural safety, expediency for the patient, and efficacy of the procedure for definitively treating the CTEPH. And similarly, there's tremendous potential for innovation around integrated multimodality imaging to help improve the efficiency and accuracy of these procedures going forward. Now, overall, BPA, compared to a lot of things we do in interventional cardiology, is a procedure in its relative infancy in the US. But it is a key and growing part of the armamentarium available for treating CTEPH patients. So it's going to be very exciting to see how it develops over the next decade. And I thank Dr. Agarwal for his excellent presentation on this new and innovative technology. Thank you.